Good morning. I hope my screen is visible to all.
Yes, sir. Yes.
Thank you very much. So I welcome I thank Dr. Chandan Das and I welcome the esteemed discussants on this expert panel list. And so we'll be discussing a case of metastatic RCC. A case is of a 57-year-old male who has retired from the railway services, a resident of Rajasthan, with no known comorbidities, with no significant family history, and a reformed smoker with a smoking history of 20 pack years and a reformed for since 3 months, and occasional alcohol intake, now reformed since 3 months. So the patient has presented to our clinic with complaints of abdominal pain on and off since 3 months and right lower limb pain since 2.5 months. Upon clinical examination, the patient had a performance status of ECOG score 2. Per abdomen examination, the abdomen was soft and non-tender. There were no palpable organomegaly and no ascites. There was tenderness in the lumbosacral area, and power in bilateral lower limb was 5 by 5, and there was no sensory loss. Evaluation was done upon the same lines. So, evaluation CACT scan suggested of a left renal mass measuring 10.7 into 10.6 centimeter, involving the upper and interpolar region of left kidney. No tumor thrombus. 2.2 into 1.5 centimeter left adrenal and 6.4 into 4.7 centimeter right adrenal hypoenhancing lesion was seen, and multiple bilateral predominantly hypoenhancing pulmonary mets of varying size, largest one measuring 4.1 into 3.4 centimeter, and a large 3.8 by 3.2 centimeter right acetabular metastasis causing cortical breach at hip bone was seen. MRI LS spine was also obtained, which is suggestive of a large heterogeneous mass lesion measuring 557 into 71 into 49 millimeter along posterior aspect of the L5S1 with destruction of the spinous process and lamina vertebrae. Mass was isointense on T1 weighted and heterogeneously hyperintense on T2 and stir sequences with multiple foci hypointensity, severe compression of thecal sac and cauda equina. The laboratory parameters at baseline were calcium was 9.1, hemoglobin 8.2, TLC was 9.84, platelet was 5,92,000, RFT and LFTs were within normal limit. So we got a renal biopsy done, which was suggestive of conventional clear renal cell carcinoma for Furman nuclear grade 3. IHC was positive for CD10, while it was negative for CKIT and CK7. So final diagnosis was a 57-year-old male, clinical stage T2B, N0M1, stage 4 RCC. IMDC risk group was intermediate. Over to you, sir.
Thank you, Dr. Sachin. So we'll discuss a few of the questions and relevant questions here. So my question to Dr. Rakesh. Dr. Rakesh is here, right? So
yes, I'm there. Good morning,
Dr. Rakesh, and it's an open question also. So my question: how frequently are you using the risk stratification whenever you are planning for a therapy for a new case of metastatic RCC? And which is your favorite? It's IMDC versus the MSKCC version.
Sorry, I didn't get the second part of the question. Which is my favorite?
So whenever you are deciding a treatment for metastatic RCC, which is the most commonly used IMDC in your clinical practice, IMDC versus MSKCC, and how frequently are you actually using this method stratification in deciding your treatment options?
So, Dr. Das, thank you for the question, and thank you organizers for giving me this opportunity. I am using the risk prognostication criteria almost every of metastatic RCC when I'm trying to select a systemic therapy. And let me divide the systemic therapy into 3 different eras. The first era was the era of cytokines, where MSKCC was used as risk stratification. Then came the era of targeted therapy and tyrosine kinase inhibitors, where IMDC was the modified criteria which we use for risk stratification. And now we have moved on to immunotherapy, where we're still looking for ideal prognostication factors. Currently, I'm using the IMDC criteria for risk stratification for MRCC for systemic therapy.
Dr. Sujit, so the IMDC was already the most robust evidence for IMDC is in the front line. Recently, if you go to the IMDC online database and also the NCCN, they updated it for almost every front line, second line, third line, fourth line, even for the non-clear cell also. So I would say the other options other than the first line, they are only for prognosticate, not deciding the factor. And the question here is the patient with intermediate IMDC. So in your normal practice, are you going to use the...
Excuse Chandan, Chandan here. Isn't this an high risk IMDC? I'm just wondering, because the platelets are above the limit of normal, the hemoglobin is lesser than the limit of normal, and the diagnosis is less than 1 year. That means the upfront newly diagnosed case. So making it 3 points out of 6. So it's not a high risk.
3 points. Dr. Jatin, next page. So it's a 3 point. Dr. Jayachandran, you are right. Actually, it's a IMDC port. It's wrong related. It's intermediate because it's a high thrombus platelet is high. ANC is also higher. Actually, it's more than 7,000. Also, there is anemia and obviously in the probability. So next page.
Four factors. So
next.
Put my point.
Next. So the question, I just want to ask you the questions. Are you going to use the IMDC for the prognostication in second, third or fourth line, or most often you are using in the front line for treatment certification? Because this is the obviously the most newest, I would say, the update from the IMDC. In fact, they updated the second, third, fourth, fifth, also fourth line also. So my question, are you using this for other line also?
No, there are two parts to this thing. IMDC is the only scoring system which is validated in the TKI era. We don't have any other option. MSKCC is in the interferon era. So this is the only option that we have. Having said that, currently the first line agents that are approved, be it axitinib pembrolizumab or lenvatinib pembrolizumab or even nivolumab ipilimumab combination, they are saying the treatment is irrespective of the IMDC criteria. So yes, for prognostication we can use, but the final decision on the drug that we are going to choose is not based on IMDC. We have definitely in our setup, we have the financial constraints when we come for the decision of treatment, but IMDC definitely help us in prognostication. And second line, third line, I don't think it has much relevance because the treatment options would be definitely based on the first line. So I use it for the first line to know the prognostication, and to decide. Now, suppose we have an option where we don't, the patients are not affordable for immunotherapy, and we have an intermediate or high risk patient, then we might actually consider for something like cabozantinib rather than going for a sunitinib or pasopanib, especially when we have the generics available. So I would say that in that case, again, it might be useful, but usually it is for prognostication. The treatment decision is based on the other factors, especially the logistics.
Absolutely right, Dr. Sujit. Obviously in 2022, we need an updated version of IMDC, and in fact, IMDC is doing the same thing. So it will incorporate the IO drug with TKI also. We'll get a new update very soon, actually. So, Dr. Jatin, please continue next. Yeah, please, yeah. Dr. Jason.
I just want. Of course, please don't mute me when I switch on the mic.
Okay, please continue.
So, see, originally this MSKC and IMDC were designed for the risk stat almost PHN. Now, of recent, a lot of trials have started using it for predictions. I don't know all of them whether they predict it very finely is the question. As we wait for the next update. That's what I want to make a small comment about.
Yes.
Dr. Jatin, next.
Yes, sir. So at upfront, the patient was worked up for TKI fitness and was found to be fit and was started on sunitinib 50 milligram OD dosage. And PAL-RT was offered to patient to L5-S1 region and right acetabular lesion. And he was started on monthly zoledronic acid infusions. So over to you, sir.
So it was around a couple of years ago. That's why it started on the sunitinib as a frontline therapy. Suppose this patient is come to you in today's clinic, is a intermediate or poor risk, So what is your preference? I'll start from Dr. Abhishek, and Dr. Suresh definitely can join. So,
So yeah, so as was rightly said previously, it's a high risk case. IMDC would help you just write it on paper. Clinically, it looks obviously a very high risk case, lot of meds, bad disease, and if the patient is affording, you would have an option of using a immuno or immuno TKI upfront. But if the patient is not affording, as is the case in majority of our patients, you would go with the TKI. We have the generic options available, so it could be cabozantinib, which is a slightly better than sunitinib maybe, but then any of the TKIs.
Dr. Jatin, next. So my question to Dr. Suresh, Dr. Jatin, next page. So next page. Sorry. So previous page. So the cabozantinib, I just want to show you the difference. So Dr. Suresh, so the cabozantinib is now almost around 2 months now in India. How is your experience of cabozantinib versus sunitinib? So because it's a fairly new drug, right? Previously, we don't have access to cabozantinib. It's a fairly new drug. So you have a lot of slightly different, I would say, side effect as compared to sunitinib. But obviously, I just want to know your experience on this cabozantinib. Will help us actually knowing it's better as a drug.
I'm sorry, but this one I think I will not be able to answer because I have no experience using cabozantinib. We in the government setup take about 5 to 6 months to get a new drug into our system. So before we are able to use it. So I personally have no experience using cabozantinib. So since it's just come into the market, so I think anybody else who's got experience using it can answer this question.
Dr. Tarachand, Dr. Vivek Venkat, any experience of the I would say the toxicity profile, and I just want to know the doses you are actually comfortable with starting.
Yeah, Dr. Chandan, we are using cabozantinib. Just I have used in only a single patient, but in second line, and the experience was that the patient was initially on the TKIs, then progressed, and then I stopped TKI and started on immunotherapy, nivolumab, but patient started deteriorating. Patient went on oxygen also, but patient was helpful. So I added cabozantinib 40 milligram, and within a week, patient was off oxygen, and patient is now coming in to my OPD like PS is ECOG 1 only. And the only toxicity which I observed with the cabozantinib was only the grade 1 hand-foot syndrome and the grade 1 skin rash. That is their diarrhea and fatigue. She could not mention. I think she is already experiencing fatigue from the son's sunitinib followed by lenvatinib plus everolimus. Now patient is on cabo plus nivolumab, but she is experiencing grade 1 hand-foot syndrome that is showing to me regularly, and the skin rash also. That is resolving whenever I give her doxycycline 100 BD for 5 to 7 days. That rash dissolves. But no other clinical toxicity I have observed till now, since 2.5 months have gone.
So, Dr. Vivek, any other toxicity you are experiencing on the cabozantinib or the similar kind of situation with sunitinib and other drugs?
No, sorry, I'm basically a uro-oncologist, so this I will refer to the medical oncologist for their expertise.
Okay, Dr. Vivek, it's fine. The next page, Dr. Sachin. Dr. Jatin, next page. So suppose there is options, there is no financial difficulty and financial challenges. What is your preferred IO combination? Dr. Jayachandran and Dr. Sujit, anybody can join us, please. Dr. Jatin, the next page.
Yes, sir.
So I just want to summarize the previous one, sorry. So I just want to summarize all the options available for us. I think every other drugs are available in India now. So Nivo-IP combination with Aggi Pembro, the cabozantinib, nivolumab, Len Pembro, the most recent one, and even the Javelin Renal 101. So what is your preference? I just want to highlight the PFS also just for a comparison point of view. So what is your preference? Suppose it's a patient, you have almost 5 options now. So what do you want to give to the patient?
So Dr. Chandan, here. Regarding this patient, I think is a railways patient. It will be affordable for immunotherapy. I think railways will reimburse.
No finance.
One thing which I noted upon. I think these are all options are available, but what option should be the most financially uh, giving not toxicity is something I would think is Ablimab is acceptable. The problem is the pembrolizumab and nivolumab have a support program, which I think they won't support these combinations. Nivo, if you use, they won't give Nimo as the support program. If you use Axi-Pembo, they don't give it as a. They didn't get official DCJ approval for Axi-Pembo. They didn't give official DCJ approval for Nivo Cabo, and neither for the Pembrol and Vatinib. And also they're not giving the support schemes for all these trials. So if you're going to use, it is going to double the cost for the patients. So leaving away, so with all these things, I would prefer to go for accident with Avilumab because it's the only DCJ approved combination which will be of the same cost. Otherwise, if you look at the toxicity profiles, the Avilumab accident has a bad rash. So patients are intolerable and they stop accident. We have to continue only Avilumab. But regarding this Lenva with pembrolizumab, I'm very interested because we were using a lot of lenvatinib in the HCCs and people used to tolerate lenvatinib very well. But the drug dosage is different. When I accept the higher doses used in RCC, I would be happy to try pembro with lenva as my first line after pembro lenva is approved with the support scheme. This would be my take. And the Epinivo, I'll be too cautious because toxicity profile and immune toxicity is very high. And I would think twice to start in IO combination. But I would be erring on the side to go for Pembro with lenvatinib as my choice.
Dr. Das, can I say something?
Yeah, please, Dr. Rakesh, please.
Yeah. So I think all this data about combination therapies in the first line is very intimidating. When I select the first line therapy using combinations of two different drugs targeting two different pathways, I need to have a backup plan. Backup plan for two reasons. One, if this combination is not tolerated by the patient. Number two, if the patient progresses, what next? So most of these patients, I have still not been able to practice combination therapy. I give single agent because you always have a chance of giving an immunotherapy or a TKI in the next line. But I need to change my practice because now for poor risk patients, these combinations are very useful. As Dr. Jayachandran mentioned, I think a TKI with a immunotherapy with good patient assistance program is one of the best ways to go forward.
Thank you, Dr. Rakesh. And Dr. Jatin, can you go to next?
Can I add a word? It's Dr. Abhishek here. So basically, in our case, the guy was very symptomatic, had a bad bone mass compression, a lot of symptoms. Obviously, you would love to use a Nevo and EP, but probably there is one way which I select my patient. If finance is not an issue, I would go with a TKI plus immuno in a case who is highly symptomatic, but because I'm not very sure whether my dual IO inhibitors would give him the symptomatic benefit immediately. And maybe if the patient is mildly symptomatic, has no troublesome problems or impending compressions or needs immediate resolution of symptoms, I would use an IO. Finance no bar. So in this guy is highly symptomatic as of today. So using an IO would be a challenge. We might land up into a trouble. He might lose his limbs, and probably a TKI would give him immediate response.
Thank you, Dr. Abhishek. Dr. Jatin, to the next page.
So we got a response scan done. So response evaluation after TKI was suggestive of a radiologically stable disease at all sites with no new lesions, and patient had an improvement in performance status to ECOG-1 and had reduced pain. Post the 1 month of response scan, patient presented with grade 2 fatigue and new onset right posterior thigh pain. We got a CECT tap done, which was suggestive of mild increase in the renal mass size to 12 into 11.5 centimeter. Still no tumor in the no tumor thrombus. There was a new onset 3.3 into 1.1 centimeter necrotic deposit.
Dr. Jatin, please continue.
with grade 1 fatigue only, but post cycle 4, patient developed grade 3 fatigue, fever, grade 2 diarrhea with blood in stools. So the differential diagnosis at this point were kept as acute infective diarrhea, CMV-induced diarrhea, or immune-related adverse event, colitis, and patient was started on IV antibiotics, hydration, stool examination, and cultures were obtained. A gastroenterology opinion was done for colonoscopy and biopsy. Colonoscopy was suggestive of multiple large ulcers. HPR was suggestive of chronic inflammatory infiltration. CMV was negative, and colon biopsy was suggestive of colitis, possibly nivolumab induced. Steroids were added to the treatment, and patient improved with this treatment. Over to you, sir.
Thank you. So this is the patient who is initially treated with TKI. On progression, he started with nivolumab, and after around 2 months of treatment, he started having diarrhea. It's initially non-bloody and later bloody. So the possibilities are endless, obviously, starting from infection, immune related adverse effect, and obviously any other malignance, other type of infections, and other disease also be there. So whenever you see a patient, what is your first or foremost thing to do? How you approach a patient with immune colitis or suspected immune colitis, I would say. Dr. Tarachand, Dr. Suresh, anybody can answer this?
Yeah. So I think when a patient on immunotherapy develops diarrhea, and luckily in this case, I think the patient is only on immunotherapy, not on VEGF TKI also. Otherwise, it would have been double complicated. So when the diarrhea occurs, the first thing that occurs to our mind is, of course, immune-related colitis, especially if the time duration is at least within about 1 month to 3 to 4 months, I would say. 1 to about 4 months is the usual time when these patients develop diarrhea. So the first thing always is to rule out an infection. That would be the first part, which all of us do. We send the stool cultures and the stool for the cryptosporidium, ova, and amoeba and all that. So we send them for that and then start on antibiotic therapy, and along with that hydrate the patient well, and add on loperamide if the diarrhea is severe. If the patient does not improve, then within 24 to 48 hours, then we also go for a colonoscopy and biopsy. And if it is very severe, we may even have to, in this patient at grade 2, but if it is grade 3 or grade 4, we may even have to start steroids along with our antibiotics pending the reports that are yet to be received. So I think rule out infections and investigate for all infective causes, and try to also investigate for immune-related colitis, as well as start treatment. Don't wait for all the reports to come. The patient may become too serious. I would put it that way.
Jatin, next page. So Dr. Tarachand, so recently, so just the progression of the incidence of toxicity, if you see here, the diarrhea and colitis started around 6 weeks from the onset of starting of any immune therapy. This is valid for all nivolumab and most of the immune checkpoint inhibitors. So Dr. Suresh, you are absolutely right. So around a month later, if anything happens, we would suspect definitely it might be due to the immune colitis or immune related side effect. And absolutely we tried infection first, which is most often this is the offending agent, I would say, all the Clostridium, all type of infections starting from Cryptosporidium and other histolytica. And recently there is one I would say better way to when to do endoscopy in patient with immune colitis. So if you can assay the lactoferrin on calprotectin, which is measured in this tool. So if you have a high elevated, then that is the indication of doing the endoscopy. So this is most, I would say, most recent recommendation in immune checkpoint inhibitor colitis. Previously to use for the IBD thing. So if you have a high calprotectin or lactoferrin, do an endoscopy just to rule out any other infections. So similar kind of we can try. I personally never tried.
And we should take a biopsy also, right?
Obviously,
I think we should take a biopsy to
and
rule out that immune related colitis or not. I think
that is the, I would say, most important point. Biopsy should be a must. If you are doing colitis, do a biopsy. Otherwise, there's a high chance we will missing something. And obviously,
because
as you
otherwise
said,
we will start
options.
steroids and the patient will be on antibiotic also, and then we will miss the window of the infection also, and infection may play.
Yeah. So,
1
Dr.
minute left,
Charathan, how
sir.
often your patients are everybody is responding to the steroid prednisolone or methyl prednisolone, or sometimes you have to use the other suppressants like infliximab and other cyclosporine, IVIGs also. So most often, what is your experience of treating the checkpoint inhibitor induced colitis or any other checkpoint toxicity? Most often you manage with steroid or you have to add something else also.
Actually, in my practice, I did not experience like immune-related side effects till now. For the patients, you can say the hardly, or I have treated only 15 to 20 patients with the immunotherapy. That's why the number is less. So I have not experienced the immune-related serious side effects till now. So whenever it will come that during my training time, it was one immune-related pneumonitis we observed, and that responded to the steroid very well, and very beautifully also that patient improved within 48 hours from oxygen dependence to the of oxygen. And this was immune-related pneumonitis, not the colitis at that time. And one patient was also there that developed the ipilimumab-related transaminitis, but we could not save that patient.
So 30
that was the
seconds
first
left, sir.
experience.
Sure.
Yeah, I had two patients of lung who had pneumonitis with one was with first dose of pembrolizumab. It was in lung cancer, but he was 80-year-old. He had a base, he had a COPD on before, and then he had a very, in spite of steroids, he improved, but he was not improving very fast. And there are another patient on after 7 cycle of atezolizumab, small cell carcinoma, pneumonitis, responded very beautifully in 1 month. Steroid 1 mg per kg. We are on tapering dose, but he's well. In colitis, I don't have any personal experience.
Thank you, Dr. Sajid. So,
Can I interrupt here,
Dr. Jatin
please?
will end here only. So, the crux of point, managing the immune therapy, they are very well responding to steroid. Obviously, if you identify in much later, the crux here within 2 to 3 days, if it's not responding, try to use something else, means any other immune suppression. That is the last message I would tell to everybody. So, within 2
Can I
to 3 days,
interrupt here,
not responding,
Chandan
do
Das?
something else. Thank you.
Dr. Chandan Das, I would like
Yes,
one question to be asked to the surgeon who was there, Dr. Vivek.
Yes, ma'am.
I'm really sorry. Actually, definitely, I have a question, but it's slightly unrelated to the metastatic
but you know,
RCC.
Yeah, but we would like to have his opinion regarding the role of nephrectomy in stage 4 disease, and also the role of metastectomy. So,
Yes,
Dr. Vivek,
My Dr. Vivek. So I have just a modified version of these questions. So do you remember the Carmera trials come in the presence at that time? We have only TKIs, right? The TKI, the response rate is only 30%. So you have now the IO and TKI with a response rate of reaching up to 60%. It is. So do you still feel the metastatectomy and the removal of the primary, it still holds true in the presence of IO and TKI combination?
Right. So first of all, I see definitely in high risk, if you classify these patients as the poor risk category, definitely there is really no role for upfront cytoreductive nephrectomy. In intermediate risk, if there's a possibility of simultaneously completely removing all disease, whether a single metastasis or 2 metastasis, which can also be removed at the time of nephrectomy, and then you can delay the systemic therapy, then maybe there is a role. And the third, only other one is a very symptomatic patient who's bleeding or severe pain from the primary. Those are the cases where you can offer a palliative nephrectomy. But other than that, right now I think the role is very minimal. And but unfortunately, even though TKI and IO is still has a very good response, still the maximum number of patients are still on sunitinib only.